Thank you, Dr. Kavya, for including me in this interesting instruction course. I'll be talking on patient selection, preoperative evaluation, and to do DSEC or DMEC, and secondary IOL, which I will to choose in aphakic bullous kyphopathy. Endothelial keratoplasty provides rapid visual rehabilitation and is the current standard of care of treatment for endothelial dysfunction. However, preoperative assessment is mandatory to assess the vision-limiting ocular comorbidities. The most important thing is patient selection. In patient selection, we have to assess the eye to know the intraoperative challenges, to assess the previous surgery. I mean, whatever wrong things have gone in the previous surgery, that you have to assess, and to plan the post-operative management. And also, you should look for the general condition of the patient, whether he can come for the therapeutic regime regularly, and he'll stick to the compliance, and whether he'll adhere to the medical regimen. And one more important thing is you should assess his expectations. Patients with unrealistic expectations, we should counsel them properly, and we should tell them what is the procedure, what we are going to do. And most of the patients, they compare with surgery means cataract surgery, and they expect a vision, very rapid vision, immediate post-operatively. So usually I have an animated video in my room, and I'll show them actually what exactly we are doing, and what is the expectations post-operatively. EK surgery in aphakic eye is more difficult due to because there is no support of the iris lens diaphragm. So in the beginnings, in the beginners, the lens, the graft may dislocate into the vitreous. And most of the patients, they will undergo vitrectomy. In the aphakic patient, most of them will undergo vitrectomy. If there is aphakia and vitrectomy, the eye tends to collapse during the surgery. That you have to keep it in mind. Pre-operative evaluation, you have to do in detail everything, and in leads, you have to look for especially MGD, that we have to treat, because the bullous keratopathy has an unhealthy ocular surface. Added with MGD, there are more chances of infection, because also we keep a BCL on the eye for longer period. So if there is MGD, you have to treat it properly before taking up surgery. And also look for narrow palpebral fissure, deep socket, and if there is exaggerated bell phenomena, it will be very challenging for the surgeon. And also this helps us to decide which approach to do, whether we have to do temporally or superiorly. The deep socket and narrow palpebral fissure, if you go approach temporally, it would be easy. And conjunctival, look for any conjunctival scars of the previous surgery. And depending on, we can plan for a site of the wound. Recipient corneal status assessment is very, very important, especially in ABK. And one more wise thing is, if there is a very severe end-stage bullous keratopathy and full thickness corneal scarring, it is better to go ahead with PKP rather than endothelial keratoplasty. And also, we should note down extent of the edema, whether it is a diffuse, there is a localized, and how long-standing is the edema, because that would also help us to visualize the entry chamber during surgery. And if there is very severe edema, we can plan for some aids which will help us to visualize in the intraoperatively. Corneas with relatively good endothelium at the periphery will have less symptoms post-operatively because they will not have a bullae or edema post-operatively better. And also, if the whole cornea is involved, it is better to do a large graft. And you have to note down the corneal vascularization, and it will help us to do intraoperative cautery to reduce the vascularization, and we can plan for a post-operative more potent anti-inflammatory or even immunosuppressions. And also, you should counsel them, they need a longer follow-up. The assessment of entry chamber is very important. If there is a shallow entry chamber, it interferes with all the steps of the surgery, starting from this section. And also, it will lead to high vitreous pressure, which in turn leads to iris prolapse, vitreous loss, suprachoroidal hemorrhage, and sometimes graft may eject itself while doing surgery. And very critical examination is status of the iris in the ABK. You have to look for the iris defects, sectoral iridectomy, correctopia, whether there is a PI is present, whether there is irregular pupil. This would help us to plan for secondary IOL and also graft handling in the antechamber. In case of previous failed graft, you should assess the previous graft size, graft attachment, and whether the graft hose interface you have to look for. And you have to do a dilated pupillary examination whenever there is a visibility. Sometimes these surprises may be seen because although it is a aphakia, sometimes you have seen these surprises with IOL has gone down and subluxated IOL and CTR IOL complex subluxations. Preoperative investigations include anti-segment OCT, UBM, and B-scan. AS-OCT will be very useful in previously undergone graft because we can assess the graft host interface, and also we can plot which EK to do, whether to do DSEK or DMEK. And also you can look for the scarring of the cornea and edema of the cornea. How thick is the scar, and we can plan whether we should go with EK or PKP. Sometimes because of the cornea is not clear, sometimes we find these surprises, anaredia, and also antechamber angle of the structure of the antechamber also we can assess, and depending on we can plan the surgeries. UBM also helps for implanting secondary IOL. This is a one case. It has a good sulcus space here. So we can plan a sulcus fixated IOL before going to endothelial keratoplasty. And we can see paths and status of the PI, whether it is patent or not patent, whether there is any obliteration of the PI we can assess. Sometimes in UBI we can see these surprises like angle recession, subluxated PCIOL, angle closure, and iris cyst also. So if they are there, they are to handle them separately. B-scan is very important examination. Apart from knowing the posterior chambers, sometimes in aphakia we can see the dislocated graft in the vitreous cavity. Axial length you have to measure to know the calculate the intraocular power, and also we can come to know whether the patient is myopic or hyperopic, because shallow AC and deep AC it will be difficult to unroll the graft. And also we can assess whether there is an anterior microphthalmus. IOP measurement is very important, and whether there is any glaucoma, you have to treat it before going for a EK. And which IOL to choose? We have a lot of IOLs, secondary IOLs available now. We have sulcus fixated IOL in cases of intact sulcus, and iris fixated IOL if there is iris is in a good status, we can think of iris fixated IOL. And there are variety of scleral fixated IOLs available nowadays, and sutures scleral fixated IOL, glued scleral fixated IOL, and recently MNA technique, and everybody is doing this technique and more enthusiastic of doing this MNA technique. And one of my co-speaker is talking about it in detail. And IOL is a mandatory to build a barrier to previous vitreous cavity for proper air bubble support and at the end of surgery. So any aphakic bullous keratopathy, it is better to do a secondary IOL first, then go in for a endothelial graft. So whether to do DSEK or DMEK. DMEK is pushing the limits because we know what are the difficulties and how to overcome the difficulties, and training and all the surgeons has become more now. So more and more people are doing DMEK, and even they are doing in all the complicated patients DMEK. But the decision depends on the surgeon's experience and his competency. And both gives a good result, and the decision depends on the surgeon. And some of the conditions which will favor DMAK are absence of stromal scarring, deep AC, normal anatomy of the entry chamber, and presence of stromal scarring, shallow or irregular AC, complex anatomy of the entry segment, and posterior vitrectomy eyes will favor for D6 surgery. This is a short video, but Dr. Kavya is talking about ABK with iris fixated IOL. But Dr. Kavya is talking in detail about it, and I'll stop here. Thank you for your patience here.
Thank you, Dr. Mallikarjun. Actually, the point that you raised about UBM was very, very important, especially when you're considering different types of IOLs, considering AC IOL, even iris claw, and even I think we have a segment of glued IOL. I think UBM is something people don't stress too much, but in this case, I think its importance is really warranted, especially chronic bullous keratopathies, ABKs. They will have some form of pass somewhere, or the sulcus might be inadequate, and it really helps in taking a call. It's not a routine part of our investigation, but the scans that you showed, they are very informative, and I think it should be a part of investigations when we plan a complex ABKs with complex anterior segment.